Welcome to the What About Rural Health podcast, a place where research, policy, and real-life stories come together to ask the critical question: what about the communities too often left behind? I am Chinasa, a development and global health policy strategist, and for me, this work is personal. From the village health workers struggling with limited supplies to the mothers working miles for care, their stories shape the policies we need. Join me as we uncover challenges, spotlight innovations, and amplify the voices of those at the heart of rural health systems. Because every community matters, and it is time the world listens. Hello and welcome. You are listening to the podcast that asks the question many forget: what about rural health? I am your host, Chinasa Imo, and together we are uncovering the stories, challenges, and innovations shaping healthcare in overlooked community. And today we are discussing equity in action, how designing public health systems is aimed to reach everyone or would aim to reach everyone. And we have Dr. Ifeanyi M. Nsofor. He is a global health equity advocate. He's a researcher and a public health physician. This is an introductory episode, and in this series, call it Breaking Down Rural Health Issues, Advocacy and Systems Reform. What we are looking to do with this episode is to foray experiences, practices, and professional expert opinion around rural healthcare service delivery across the globe. So people wonder and be like, are you a physician? Are you a doctor? Someone reached out to me and like, you are a doctor. Can you tell me what to do with my health issues? And this is on Facebook. And I wrote back to the person, I'm like, go to the doctor. I'm not a doctor, for God's sake. I only study the intersection of governance and the health systems as a public policy person. And over the years, I have kept track with Ifeanyi as someone who I enjoy the level at which he puts his expertise into producing like real factual but mixed experiential conversation around health, specifically in Nigeria and across Africa. And at some point, I reached out to him. I'm like, you should definitely have this title, Ichie Public Health. And in Igbo parlance, where I come from, when you are called an Ichie, it means you are an elder, a grounded statesman, and a stakeholder within a particular, whether is community, whether like you're a thought leader in that environment. So, and I look at all around his work over the past 20 or more years, and I'm like, yeah, he is. I don't know anyone whose job cut across that. But I need to give you his formal dossier before we dive into the topic of today. So Ifeanyi Nsofor is a public health physician, global health equity guy, and he is the co-founder and board member of Africa Behavioral Science Network. And he was telling me today that through this network, they are developing capacities of public health professionals across the continent of Africa to for behavioral attitudes and how they can use that to understand improving access to healthcare in local and rural community. I just smile because I haven't even heard about this project, and I already know why I gave him that title. So he uses behavioral insights, social media, and community pharmacies to increase vaccine uptake in Nigeria. He has over 25 years of experience across Africa and the US. He is a senior Atlantic fellow for health equity at George Washington University, a senior New Voice fellow at the Aspen Institute, and serves on the Global Fellow Advisory Board at the Atlantic Institute, Road Trust, Oxford. He has co-founded a lot of things, and he is top 100 of most influential African by New African Magazine in 2020. 2020. So welcome to the studio, Dr. Ifeanyi.
Thank you so much, Chinasa. I mean, it's a pleasure to be here, and thank you for that, for the title of Ichie Public Health. It's a title that I'm very, very proud of because, of course, the deep meaning, but also the fact that it also helps me celebrate my heritage as an Igbo man. So, yeah, thank you. Thank you for having me.
Thank you. Thank you very much. So why do you think that health equity is both a local and global equity issue?
Well, because really the foundation of healthcare, to me, it should be centered around equity. Because when you think about it, health equity is about people having access to the healthcare that they need that meets their present circumstance at that point in time. So wherever it is that you're located, based on the prevailing situations around that place, you deserve the healthcare that you need to be able to function properly there. And as somebody who has worked in and continue to work in health equity, I like what the University of Global Health Equity says about health equity. When I went there for an executive education in 2019, they had this statement on the wall that says, achieving equity in healthcare depends on equity in health education. So for me, everything really should be centered around health equity, no matter where it is, but most importantly, in rural communities, because primary health care should be the bedrock of care. And if we can get healthcare access in rural communities, then I think, especially from where both of us come from, I think we're going to really make huge advancements in equity in healthcare.
I absolutely agree with you, and thank you for making reference to education, because that is something that we often overlook when it comes to healthcare delivery. And I want to angle this for you to discuss a little bit about the vaccine uptake initiative. And I know I skip it intentionally when I was introducing you, so that you spend a little bit of time to talk to us about this current work that you're doing on vaccine uptake.
Okay. So the work that we're doing is part of the WARH social initiative, WARH social, as the name goes, vaccine social media, to see how we can use social media to increase vaccine uptake. So it's a consortium of 4 organizations, 2 in the US, 2 in Nigeria. And what we pitched from the beginning was that social media, we felt, because we had done work in COVID-19 vaccination using social media in Nigeria during COVID-19, and we saw the impact of that, especially when you bring in behavioral insights into that work. And the fact that more than 50 million Nigerians are on Facebook. And the way I look at it, the way I try to interpret it is that if every Nigerian on Facebook made up a state in Nigeria, it would be the largest state in the country. Just to show you how very impactful social media, but particularly Facebook, can be if you deploy it very well. But one other thing that we used to make the justification for that project before we got the grant was that if you look at healthcare access in Nigeria, the bulk of it is provided by community pharmacists as well as chemists. And I know that people are polarized, especially health workers, doctors, nurses, about the role of community pharmacists, and chemists in this. But this is where people go to. If you look at the total health expenditure and seeing that close to 23% of that is spent in chemists and pharmacists. So based on that, we came up with this project using community pharmacists as hyperlocal influencers and social media as a place where lots of Nigerians, transact different businesses on. So we're using Facebook, Instagram for social media. Then we're using community pharmacies. So we have community pharmacies that are already trained. By the way, community pharmacies in Nigeria are actually run by qualified pharmacists, people who are trained pharmacists, different from patent medicine vendors. So I think it's important to make that distinction. So they are trained, caregivers come in to transact their business, buy medicine, or ask them questions. They provide information about HPV vaccination, answer the questions they can answer to the best of their abilities, but most importantly, they direct the caregivers to a primary healthcare center that we've already identified that is closest to them. Then the social media side, we we create content on social media, targeting caregivers of girls aged 9 to 14 years, providing information about HPV, but also directing them using social media and mapping to direct them to the PAC closest to them. For us, a very important factor that brings us all these two together is the behavioral insights. So we conduct behavioral surveys to look at motivations and abilities that people have. And based on findings from those surveys, we use that to, for the social media content creation. So it's been very interesting. I mean, the project has been running for about a year now. We're going to end in December for this first phase. Through social media alone, we've reached probably, close to 5 to 6 million people in 3 states, in Abuja, Adamawa, and Nasarawa. Then the pharmacists engaging with caregivers in the communities where we work also have a database where they enter their interaction. Close to 9,000 direct interaction with caregivers, with the pharmacists. And also, one thing we've introduced is using pharmacists themselves, apart from their influence in the communities, we also use them to create content on social media. So they send us photos, short videos that we use. So especially when you do, targeting on social media, you're targeting within that locality where they are. So it's people that already know them, see them, interact with them. That also helps with motivation. So it's been a very interesting project, and we're seeing great results from that.
Thank you so much. I when you are explaining, it drew me back to maybe probably around 2017. I had consulting work with USAID in Ebonyi State to do this mapping about, it's a SVBC project to do mapping on reproductive health uptake. And it falls back to, so when you're talking about pharmacists and the role of pharmacists in rural community, as even before the PHCs, the pharmacists are literally the first point of contact for people seeking care.
Yeah.
And that came up very well in that research that we did in Ebonyi State. And it's just so amazing that when you mentioned the role of pharmacists in expanding access to care, and I just smiled. So the question that I wanted to ask you in relation to that is, besides coverage, what successes have you seen on ground with this initiative? Because you can reach 1 million people with a message, with a content and everything. But in terms of service improvement and access improvement, but uptake improvement, what have you seen happening on ground on this project?
Okay, some of the insights we're seeing. So like I said, we do periodic behavioral survey. The last one we did was in February. Some of the things that we're seeing. So for instance, now we found out that caregivers of girls aged 9 to 14 years in Nigeria, in terms of the type of messaging for public health, for HPV vaccination, they are more interested in messages that inspire hope instead of fear. And if you look at the traditional risk communication kind of messaging, it's fear. If you don't do this, this will happen. If you don't do this, you die. So, but the way that the behavioral insight is showing that, look, people want information about HPV vaccination that inspires hope. So the kind of content we create, for instance, will be like, you vaccinate your child so that you can give your child a better future. So that your child can grow up to be, the girl child can grow up, at least for now in Nigeria, can grow up to be something, somebody of influence and things. So hope-inspired messaging is something that our behavioral insights are showing us. Another insight we're seeing is that the agency of the girl child also influences the parents in getting her vaccinated. Because let's not forget, there's some kind of peer relations among girls, friends in school, and the fact that Nigeria has already done 2 national school-based campaigns. So the girls know about the HPV vaccination. So our insights are showing that if the girl child is interested in getting vaccinated, that also helps inspire their parents or caregivers to get them interested. And we're seeing the impact of social norms. So when you look at social norms as something that people do based on whatever it is, the prevailing situations and beliefs in their communities, we find out that caregivers, from families where they discuss HPV vaccination are more likely to get their girl child vaccinated. So very, very interesting insight. And we're also seeing that the pharmacists, there's no doubt about it. In fact, like I said initially, we've now moved to integrate the community pharmacists on the ground and the community pharmacists online. What we're seeing is that the community, getting them to share videos, share their images with us, we use that to create content, really leads to people, being more trusting of what the pharmacists are saying. And one thing is that in this particular project, we're also using influencers. So for instance, we're using Dr. Aproko, is one of our influencers.
Mm-hmm.
We're using Taoma, we're using a number of key influencers. But guess what? The pharmacy content that we use for actual pharmacists on the ground to create outperform, the social media, the so-called health influencers. That just goes to show you that, look, pharmacists are the bedrock of care as far as healthcare is concerned in Nigeria. Let me just say something. When you made reference to the work you've done with community pharmacists in mapping them before. If you look at Nigeria's national health accounts, at least the last one was done in 2016, published in 2018, the estimated total health expenditure was $10 billion. $2.3 billion of that amount Nigerians spent in chemists and pharmacies, which was twice what international donors as a whole gave us for 1 year. So even if you follow the money, you will see that Nigerians are really putting their money where their heart is, which is community pharmacies.
Thank you very much. You are still listening to What About Rural Health? We'll be right back after this short break. Welcome back. You are still listening to What About Rural Health with Chinasa. Okay, so Dr. Ifeanyi, let's dive in to look at your broader role beyond Africa, beyond Nigeria.
Yeah.
As someone who's been at the forefront of translating health equity issues into accessible communication, how do you see storytelling shaping public understanding and action around health equity?
Oh, storytelling, especially for us as Africans, this is something that is embedded. This is part of our culture. It's stories, For us as Igbo people, proverbs are so powerful. But unfortunately, I think that if you look at, despite the fact that, Africans spend more out of pocket for healthcare, what is obviously done at the end of the day is donor inspired, donor shape all sorts of things. And I think that over the years, we've actually lost, tapping into that place of storytelling. And for me, as an ambassador of the Op-Ed Project, which is a New York-based women-founded, women-led organization that trains people on how to write opinion pieces, they say two things. That whoever tells the story writes history.
And
the story that we tell becomes the world that we live in. So it's such a powerful, we need to tell stories for different reasons. One, as Africans, tapping into our innate culture. We didn't document a lot, our ancestors did not, but our ancestors told us stories, oral stories from generation to generation. And if you tap into that, it is much more, it's much more inspiring, because people are not interested in numbers, really. I know that we like us in public health, we like throwing around numbers. So for instance, if you said, if you said 80,000 women die, unfortunately, due to pregnancy-related complications every year, it hits people and they kind of move on. But when you personalize it with a story,
that's true.
Focus on one story, people are more able to relate to that. Way back when I was in Nigeria and part of Nigeria Health Watch team, I remember once we did a radio program that we called Call Her Name. It was a maternal, newborn, and child health project. Call Her Name.
And I think I remember that project.
What we did was simple. On radio, introduced to say, okay, today we just want to talk about and remember women who have died because of pregnancy, childbirth, or 6 weeks after. What we want you to do is just to call in, if you've lost someone as a result, tell us her name and just share what happened. It was quite emotional for everyone, and that is the power of storytelling. Let's try as much as possible to translate the numbers into stories. That way we're able to connect with more people and hopefully change behaviors.
Thank you very much. And I'll be shifting the conversation now to policy. Like I said, we had three-prong areas for this episode, and we've covered the first part. We've talked a little bit about the use of communication strategies to improve healthcare equitability. Now let's look at the intersection of behavioral science and health policy content. How can behavioral science, or how do you think that behavioral science can better shape how we propose, or how, health policy people like myself propose or repurpose rural health policy content that gets to the right stakeholders?
So I think for that, we need to realize that no matter what health intervention that we're implementing, everything rises and falls on behaviors of people. And those individual behaviors also tap into social norms, collective behaviors. And a lot of it, of course, also has to do with culture. In fact, I like what the great American management guru says, Peter Drucker. Peter Drucker says that culture eats strategy for breakfast. So it doesn't matter what kind of grammar you're blowing. It doesn't matter how well you've planned it. If you don't take into account people's behaviors as a result of their culture, as a result of social norms and things like that, then it's almost bound to fail at the end of the day. You could come up with very fine policies that may not work. And to me, that also means that we need to, if we have to incorporate behavioral insights or behavioral science into policy making, then surely we need to listen to the people. What are the people saying? What are the things that people do, that matter to them? It may not make sense to you as a policymaker, as a health policymaker. But I think the most important thing is that this thing is very important to people, their cultures, their social norms, the way that they do things. Then we need to really tap into that to be able to, to influence behaviors. And so that by the time we come up with those policies and it comes to implementation, then those policies are most likely going to work. But I think what we've seen over the years is that, for instance, again, going back to Nigeria, you see that people stay somewhere, come up with a policy that they think, because they think they know much more than the community people, the rural people. Nobody asks them questions. Nobody wants to listen to whatever it is that they're saying. By the time you now bring the policy to implement, you realize that, look, there's something about this particular culture. There's something about people's behaviors in this community that really makes it impossible for them to implement that thing they're talking about. So inculcating behavioral insights, cultures of our people in policy making really needs to be a bottom-up approach instead of top-bottom, and I think that's only when policies will really begin to, to make sense to our people and lead to improved health outcomes.
Thank you. You've answered half of the second question that I wanted to ask you.
Okay.
And the reason why I want to reiterate this question is so that you give us like a very clear strategy on how you think from both, policy making perspective and policy adaptation perspective. So the question is this: how do we bridge the gap between policy intent, that's the intentions of all making policy, and on-the-ground realities that is seen in underserved rural communities? How do we bridge that gap?
Okay, so I think just taking off again from where I stopped, we need to listen to our people. We need to talk to our people. We need to get their own inputs. We need to understand what makes people do the things that they do. In fact, just before I joined this call, we did a refresher training for some of the behavioral, for some of the people we've trained as part of the Africa Behavioral Science Network, and we're looking at social norms, different things that make people do the things that they do. And if you listen to some of the examples that people were giving, and you don't understand where those communities are coming from, you think that it doesn't make sense. But it does. It makes sense. Let me just give you a very short example. This is so I started work with the National Program on Immunization before this MPACD, before it became MPACD. And I remember way back in...
Sorry, can you give us the full meaning of MPACD for our...
Okay, yeah. So it's Nigeria's National Primary Healthcare Development Agency.
Thank you.
Yeah, so I worked with MPI, which was National Program on Immunization. At that point in time, MPACD was still a very small agency, but eventually both were merged and that became National Primary Healthcare Development Agency. But I was sent from Abuja then to do work in Borno State, again, before the insurgency started. And I'd gone to Gamborun Gala, which was one of the communities between border communities with Borno and Cameroon. And I got there, checked into the guest house, and the local immunization manager told me that they got feedback that one village was rejecting the polio vaccine as a whole. They didn't want it. And of course, I said, okay, he said the following morning we needed to go and see the village head so that we can speak with the man. When we entered the man's, it's a small palace, you know how it is in northern Nigeria, carpet on the floor, people were all seated, and we sat down and the local immunization manager introduced me as somebody, young doctor from Abuja, this, that, I've come to provide the campaign. And after everything, I grew up in Kano, so I can speak Hausa. So I spoke Hausa to the man. I was like, oh, okay, you're even one of us and everything. And by the time we finished, said, okay, that he's going to send out some of his chiefs to go and speak to the people. There'll be no problem. We wanted to leave, and they whispered to me and said, no, that they're bringing food for us. They need food. That part of their culture here is that if you come to visit, they're going to give us food to eat. The food arrived, tuwo with all the soup in a tray. But before the food arrived, they had passed a bowl of water. Everybody was washing their hands in that bowl of water. And by the time it got to me, the color of that bowl of water had changed. It was no longer colorless. It was brown. So I whispered back to the immunization manager, look, that, please, can you tell His Royal Highness that I'm not hungry. I don't want to eat. So the immunization manager whispered back to me and said, so you're telling me to tell His Royal Highness that you brought polio vaccine to drop into their children's mouth, but you're not going to eat the food that they're offering you? Is that what you want me to tell them? So for me, that was a huge conviction to show that we cannot provide services, policies in spite of the people. We need to listen to the people. We need to see what matters to them. We need to know what matters to them. And of course, I had to wash my hands in this same bowl of water and ate the food, and I did not die. And I use that story to illustrate the fact that you can imagine if the policy for immunization has started by consulting with community members. So if somebody is coming to meet with you, what should they do? What are the things? What are the things that people should do? How should they talk to your people? What are the different reasons why people reject vaccination? So that we can plan beforehand so it doesn't happen in that way. So for me, the first step is, consulting with the people, getting their input, allowing them ask questions, allowing them disagree, if they disagree with whatever it is that we're doing, but also creating a situation where we're able to explain to them and convince them why they should take a particular step instead of the other. And beyond that individual consultation, leadership also matters. Because, like I tell people, sometimes when I go to communities, I don't want to speak myself. I want a leader in that community to speak to them. All I need to do is to speak to the leader to explain what it is that I want, because already that person has a huge influence over them. So we need to tap into a community leadership, different kinds of leadership, women leaders, youth leaders, traditional leaders, religious leaders, tapping into them, because by the time we do that bottom-top approach, community members, leaders, local government leadership, state government, by the time we get all those insights, then we're going to have a policy that really works for everyone and not something that is foreign. And people start wondering, oh, really? No, we don't do this. This is not how we do things. So to me, those are some of the steps I think are really very important. so that it's truly people-centered and not just a policy that is done without their own consent.
Thank you very much. And if I may reiterate properly what you're just saying is center people around policy design. All right.
Yeah.
So we will take a break. And while we are having this break, I want to put out a call for volunteers. Do you want to help drive rural health forward? We are looking for passionate volunteers to support our work, from research to storytelling to collecting information and stories from rural community for our outreach. So if you believe every community deserves care, please join us. Visit the link in our bio or go to our website to sign up for this. So welcome back, and we are back with Dr. Ifeanyi Nsofor, who is here for our introductory episode. So Dr. Ifeanyi, having worked across systems, from all that you've told me, and I think this is the last question that I have for you for today's episode. Having worked across systems, what advice do you have for emerging rural health leaders?
Okay, the way I'd like to approach this question, I think, to me, I think Rwanda is a perfect example of how rural health system is the bedrock of service delivery in the country. And this is again because remember when we started, I said that I had gone to the University of Global Health Equity for a 2-week course on executive education course on health equity. And part of that course was actually going to shadow the community health workers who were providing services to the people. Across Rwanda, it's about 50,000 community health workers who are the bedrock of this. So, and the fact that these community health workers are volunteering, but they get some kind of incentives in terms of, especially because a number of them are farmers, they form cooperatives, get all sorts of things. I'm really a strong advocate for paying community health workers. But the Rwandan community health workforce really gets some incentives for volunteering their time to provide that. But you see, the thing is that those community health volunteers are at the village level. They are the health workers that the villagers know. They are the people that go about providing the right education to their people about how to keep the environment clean, about what to do to prevent illnesses. If a child is sick in the night, they can come and knock, on the door of the community health worker who would, provide some kind of advice or some kind of medication before accompanying them to the local district hospital. And the fact that across Rwanda, more than 90% of Rwandese have health insurance. So you can say for sure that Rwanda has universal health coverage. So we really need to learn from that Rwandan health system that the healthcare is not helicopter approach. It's not somebody coming from the state or coming from the from the capital city, once in a while. It is the people using their own workforce. The workforce that have already been trained on the right things to do. For example, one of the community health workers that my team shadowed during one of the visits to the villages told us that if a child is breathless, has had cough for some days, and has fever, and the mother comes and knocks on his door at midnight, and he counts the respiratory rate of that child, and it's way above normal. With all those symptoms that I've just mentioned, what he's been trained to do is to place that child on amoxil. Once it's daybreak, he accompanies the mother and child to the hospital. That alone has really reduced death due to pneumonia across Rwanda. So it's for me, the bedrock of care is rural health care. Why it is important to have all sorts of people be part of it, but we really need to tap into the workforce, and the workforce here are the people. And I think another good example is the friendship bench on mental health. That was started by Dr. Chibanda from Zimbabwe. What did he do? He looked at the community because he lost one of his clients. He's a psychiatrist. He lost one of his clients because they couldn't come for follow-up. The girl died by suicide. And, because of, I think something about $20, transport. It was a long distance. So he looked at the community and said, okay, in our communities, what is one consistent what are consistent individuals across our communities? And what he came down to was that the consistent individuals across our communities are grandmothers.
Yes.
And what did he do? He came up with the friendship bench, trained grandmothers as the first line of mental health counseling, and that is it. And the friendship bench has had, they've even done an RCT about the friendship bench by Stanford, and they've seen that it works. Last year, the friendship bench started in Washington, in communities in Washington, D.C. We need to look at our communities and say, what are the strengths that we have here? And how can we use that strength to improve the health of our people? And I think every other thing should flow from it in terms of what kind of resources are we going to put in? What kind of support do they need? How can we help them amplify the work that they do? How can we even get younger people? I've read papers where, authors are arguing that it is time for us to begin to involve young people as community health workers. Because most of the time when you think about community health workers, it's elderly people you're thinking about. It's grandmothers, it's people's parents. But people are saying that a huge part of our communities are young people. And if we want it to work, we need to really make young people community health workers so that they provide youth-friendly health services to their own demographic. So there's a lot that we have. There's a lot of, human resources that we have within our rural communities that can really help us change, access to healthcare and improve health equity. And I think this is something, for me, this is what I would advise anybody. Think about it. Alma Ata Declaration, primary healthcare, 40 years ago. But how much of that have we done? In fact, I lie, and I'm going to end with this. If you have any follow-up question, I'm going to end with this. What WHO says about primary healthcare. WHO says that 80 to 90% of the healthcare needs of any individual throughout that person's lifetime can be provided for at the primary healthcare level.
I agree with you. I absolutely agree with you. Thank you very much, Dr. Ifeanyi. I just want to make sure that I highlight key points that you have mentioned here.
Okay.
The first one is you talked about culture and recognizing structural changes and issues like within the community and using that to inform both policy design, program development, and even program implementation, because the rural communities themselves, they have the answers to a lot of the questions that we have as, as public health, designers, public health program developers. The rural communities themselves, we are designing this for, they have the answers 80% of the time. And when they do not have the answers, we need to avail them the opportunity for them to agree, to ask questions, and then we come back to the table to clarify between ourselves on what they're answering us, what we are answering them, and the gaps that is still remaining. By using that bottom-up approach, we are able to design a program that's not only that is suitable for that community, but it also provides, advantage in various ways, especially in terms of adaptation, and uptake of care. Because sometimes we design things, draw diagrams, and for many of us who like to put data together in different colors, we like to show things in numbers. These community people do not understand these numbers. For them, it's about how respectful have you been in delivering this care? How accessible is this care to us? And how affordable is this care at the end of the day? If you can answer all these questions, then we can accept, this care because we need it. I don't think a woman whose child, has high fever wouldn't want to go to a hospital, a pharmacist, or even a primary care center if she knows that these questions are answered. And for us to do that, leadership, must be prefaced from get-go. And we have to, in working with leadership, recognize the gatekeepers within the communities who make decisions and who can help us also deliver care in some way through training and orientation, and guidance and partnership. And this, you mentioned them very well, like this community leaders, grandmothers, young people. These people are very, very key in community healthcare development. But there's something that you mentioned that, struck me, and which is why you would see we talk about challenges, but also innovation. Because sometimes when we talk about rural health, we don't know the level of transferable innovation that rural health can be used to improve secondary and tertiary care. Like you've just mentioned the friendship benchmark. I think that is what you called it. And how that has been transferred from all the way from Zimbabwe to Washington, D.C. And I know somebody listening to this podcast may be like, that's a good project. Can we expand it, say, in the UK or in Australia, where we've had issues with rural care or where we had issues like this around mental health and we haven't been able to figure it out? That is the beauty of looking through healthcare from, a holistic perspective. So thank you very much, Dr. Ifeanyi Nsofor, for this episode. And I like that you've called us to build a system that do not forget the forgotten, and one that centers people in health policy making and delivery. Thank you. And to our audience that are listening, do you have rural health stories that need to be heard? Whether you're a health worker, you're a patient, you're a policymaker, or an advocate, we want to hear from you. So please share your story by going to our website. You see a place that we're collecting submissions for stories from the rural community. Share your stories and help us spotlight the realities that is behind the data. Thank you for listening to What About Rural Health. If this episode moved you, taught you something, or made you think, please share it, subscribe, engage with our other upcoming episode, and most importantly, leave us a review on our different platforms. We are in all social media platforms. Just Google What About Rural Health. In all social media platforms, you would see us there. And I will close with this saying: health is not just a right in theory. It must be delivered in practice, especially to those that are farthest from it. And that's exactly where we have begun by asking the question, what about rural health? Let us create the narrative together. Thank you very much, everyone. Bye.